Good morning, everybody, and welcome to this instruction course on low vision. So we bring to you this course from Jodhpur in Rajasthan, and me and my colleagues are going to talk to you about clinical low vision. So low vision, as you know, is very poorly developed in our country, and that's the reason why this instruction course is being presented to, I must say, a very small audience, but that's all right. And the twin goals of this course is to understand the concept of low vision and its treatment, and to develop the necessary clinical skills to identify and treat low vision cases in your day-to-day practice. So now when a person has got low vision, then there are profound implications on the social and economic life of that patient. See, the daily living skills go down, then the social interactions of the patients go down, and most of these patients are elderly, so they're susceptible to falls and injuring themselves. And that's why it's mandatory that we as ophthalmologists do something to rehabilitate them. And rehabilitation of low vision patients consists of actually functional evaluation, clinical examination, optical and non-optical aid evaluation, patient education and instruction, and proper follow-up and post-follow-up care. Now the goals of low vision management, whatever you do, whatever machinations you do, whatever treatments you give, is to maximize the visual potential of the patient. And you can do it in many ways by giving them optical and non-optical aids and electronic aids. And we'll discuss all about them in the next sections. So low vision care or low vision rehabilitation is actually a team effort. So you have the ophthalmologist on one hand who's doing the clinical evaluation and considers what types of low vision are most appropriate for the patient based on the diagnosis, the ophthalmological diagnosis, and prognosis and future medical and surgical interventions for that particular patient. He is helped by the optometrist who does the low vision assessment, retinoscopy, refractive correction, and then final dispensing of the low vision aids. And some people who got profound visual loss or multiple handicaps, then a rehabilitation specialist comes into play who does the functional vision assessment, the psychological counseling, career guidance, and orientation and mobility training. But most of us are in private individual practices, solo practices, and we don't have access to rehabilitationists or even optometrists sometimes. So we are going to talk to you about how an individual practitioner can develop low vision treatment in their clinics. So a couple of years ago, the Supreme Court also had a ruling that one has to admit low vision patients in MBBS courses. In previous years, blind people and low vision students were not allowed into MBBS courses, but now there'll be more and more low vision students coming into MBBS, so we should be very aware about the problems of low vision and how to treat them, because our own colleagues will have low vision sooner or later when they join MBBS courses. So this course is divided into 8 parts actually. This is a misprint over here. So we'll begin by definition of low vision and epidemiology, and then go on to discussing the principles of treatment and then types of LVA devices, then discuss about light glare and contrast management, then actual prescription of low vision devices, and then consider what's new in the field of low vision. So with this, I end my introduction and I invite the next speaker, Dr. Ghulam Ali, to speak about epidemiology of low vision.
Thank you, Dr. Sanjeev. I will cover epidemiology and the principle of low vision in my part. Let's begin with understanding definition and epidemiology of low vision. WHO first defined 6 categories of visual impairment in 1973. According to them, visual acuity in the range of 360 and 618 were considered low vision, which cover category 1 and category 2. Because of some fallacies in the previous definition, a working group of WHO, then WHO met in 1992 and also adopted category 3 and 4 to be included as a low vision. So the working definition of low vision is a person has low vision if best corrected visual acuity in the better eye is less than 618 to PL or a visual field of less than 10 degree from fixation, but who uses or is potentially able to use vision for the planning or execution of the task. People with low vision are legally blind, and at the current point in time there is no surgical and medical treatment available to improve vision, and they are eligible for all government benefits made for the visually impaired. According to Blind School Survey in Jodhpur in 1991, although they are legally blind, but they are not totally blind because they have some residual vision. Looking at residual vision function in such patient, the government of India came up with a functional definition of low vision, which is person with low vision means a person with impairment of visual functioning even after treatment or standard refractive correction, but who uses or is potentially capable of using vision for the planning or execution of the task with appropriate assistive devices. In essence, the low vision is a level of visual disability that causes difficulty in carrying out the everyday tasks, and its consequences are debilitating and includes loss of self-esteem, depression, injury and mortality, and it incurs a lot of expenses on the patient and on the government. Then the question is, why do so many patients go untreated? Answer is because there are so many barriers to low vision aid treatment, which can be seen in these slides and so on. Lack of training, lack of awareness about low vision services, non-availability of LVDs, lack of motivation. Low vision care is time consuming. Most of the ophthalmologists busy in cataract practice and general practice, and low vision care is not lucrative. Most of the ophthalmologists thought like that. Low vision services are not effective in helping patients. A recent study by WHO has demonstrated that there are 53 million people are visually impaired, out of which 217 million people are moderate to severe visually impaired, and 36 million people are blind. This is a global map indicating that the prevalence of low vision in India is 1.6%, and it comes under the moderate prevalence country. If prevalence is less than 1, this is a mild, and if between 1 to 2 is a moderate. These are the some common causes of low vision, like retinitis pigmentosa, degenerative myopia, age-related macular degeneration, diabetic retinopathy, optic neuropathy, etc. This is the end of my first part, that is epidemiology and definition. Now I start my second part, that is principle of the treatment of low vision. Low vision devices assist people in making better use of their vision. And there are three basic principles to increase vision, four basic principles to increase vision in low vision patient. One is to increase the definition or sharpness of the image by refraction and spectacle correction. Second one is by increasing illumination. Third, by increasing the size of object either physically or by prescribing magnification. And fourth one is the management of the glare or contrast. Remember, many conditions that cause low vision are progressive and unpredictable, so there may be a frequent changes in glasses. Also, people with visual impairment are more prone to falling. So, if someone prescribe the glasses to the visually impaired patient, so we should use the CR39 or PCN glasses because they are non-breakable type of glasses. Refraction is simply way to sharpen the retinal images, and it is helpful in about 10% of visually impaired person. As one goes away from the center of the fovea and the visual acuity drops, 1 millimeter from it, visual acuity drop. Visual acuity is only 40% of the center, and if we go away 4 millimeter, It is only 20%. It's 636 at the 4 millimeter away from the fovea. The extrafoveal retina cannot be interpreted detail of the object with same clarity of the fovea, but even this poor peripheral vision can be used to see if the image were to fall on it. That's exactly what magnification does. The increase the retinal image size so that peripheral area of the retina can perceive it. This slide illustrates the effect of magnification. Higher the magnification, the bigger the image, and the bigger the retinal spread, and the better is the patient experience. We can help the patient suffering from the pathological myopia and glaucoma, etc. by increasing the illumination. On the opposite, patients suffering from the albinism, aniridia, and achromatopsia use their residual vision is low illumination. Another aspect of light and image perception is contrast sensitivity. Contrast are more important to a visually impaired person than to a sighted person. Spatial orientation, daily living skill, and are heavily dependent on the contrast in the life of visually impaired person. Picture at bottom shows how everyday tasks look like to a patient with a disease like AMD or the glaucoma, where there is a loss of contrast. Use contrast in distinguishing utensil. Contrast border to mark the edges of the doors and the window. Contrasting cloth or the paper taped on the wall will help see wall from the distance and help prevent accidents. Door knobs and handles and light switches of contrasting color than door or wall. Avoid multicolored or pattern tablecloth. Use single solid color cloth on the dining table. These are the some conditions that needs low vision devices to improve residual vision. These are AMD, progressive myopia, HMD, albinism, aniridia, congenital optic atrophy, etc. And low vision aids are ineffective for the patient with severe PDR, severe CRAO cases or severe CRVO cases. Thank you very much.
A very good morning to our highly motivated audience. First of all, I thank my colleague Dr. Ghulam Ali for nicely illustrating the status of the disability and the various principles which we can use for treating such patients. So first of all, I would, So how do we assess this situation basically? So our aim is to identify the person's visual needs and goals. So first of all, the most important emphasis is on the detailed and extensive history. Okay, so this needs to be taken care of in high detail, because before prescribing any low vision device, this is very important to understand the patient needs and with which device he will be most benefited. Like, so low vision examination begins with chief complaint, any current problem is being treated for, and any other physical disability which might hamper the use of certain devices, like tremors and arthritis are few of the conditions where we cannot give them the handheld devices. And clinical examination including fundus evaluation is very important in such condition, because it helps us to assess the fixation, whether it is central or eccentric, because this is very important. And coming to the visual acuity assessment, when we want to assess the distance visual acuity, the preferred charts are logMAR charts. But in cases of unavailability, we can do visual acuity assessment with the Snellen charts also. And if the visual acuity is less than 660, so we need to bring the patient closer to the chart rather than reporting the visual acuity as finger counting, because neither it is standard nor it is accurate. And the other very important aspect is patient feels quite depressed whenever he is unable to read the charts. So they feel better when they are able to read few lines. And near visual acuity assessment, the main aim of near visual acuity assessment is to understand how they cope up in their daily tasks, like personal care, hygiene, eating, cooking, reading, etc., etc. Because the main aim is to improve the quality of the life for such patients rather than giving them a prescription. This is more important. So we have to ask about other factors also, like whether he is able to read normal newspaper prints or the large prints, or what is the reading speed for them. Do they feel fatigue for reading for longer periods? This has to be taken care of. We also need to assess their literacy level, because if the patient is illiterate, then we have to prescribe different devices because their needs are quite different than the literate ones. Like if the patient is illiterate and then he became blind, then they are very easy to shift to the braille, but it is not the other way around. And when we talk about refraction, the retinoscopy is very important. Okay, so if retinoscopy is not available or we are not able to do the retinoscopy, autorefs can also be used. And also where autorefs are not available, we can use the old prescriptions as a guide. They also help when we prescribe then the new prescription, because if we compare the old prescription with the new prescription and there is not much subjective improvement, then it is not a good idea to prescribe a new device or new glasses. Keratometry can also be done in assessing refraction. Visual fields, it is very important, because if a patient is having central scotoma, we have to see the presence and its size. Because if, for example, like larger the scotoma, higher the magnification patient requires than the usual ones. And we also have to see the peripheral visual field loss, because such patients require few additional devices or few irregular ones, like which are not usually prescribed, like dome magnifiers are more helpful in such patients where the visual fields are severely constricted. And we should not miss the contrast sensitivity, glare, stereopsis like parameters, because these problems adds lot to the patient's disability. Like if a patient is having reduced contrast sensitivity, he might be having lot of difficulties in day-to-day tasks, like pouring milk in a white cup, or they experience difficulty in reading pass books, like where the prints are not so dark. And such patients require few additional things, few non-visual devices along with the usual visual devices, like there may be a need of higher illumination or the typoscopes, such devices. Glare is another problem which adds to a lot of their problems. A very simple test to assess glare disability is to use the visual acuity charts with and without illumination. If the patient feels better with illuminated charts, or there is decrease in the visual acuity with illuminated chart, then that means the patient is having glare disability. So here we have to adjust the illumination conditions, or we need to add absorptive filters along with the prescriptions. Color vision should be noted, stereopsis should also be assessed. And one more important thing, we also need to do the binocularity evaluation, like whether patient is binocular or they have only uniocular vision, because few devices are based on the availability of the patient to see binocularly. And we also need to ask for the previous use of any LVA, low vision devices, how comfortable they were with these devices, or were they feeling better. Also we should see for the oculomotor skills, like tracking and scanning, because they play an important role in daily mobility and the daily activities of the patient. One should also ask for the performance of the patient in various lighting conditions, whether he feels photophobia, is it mild, moderate or severe, or is he requires additional light or normal illumination in the indoors, whether he feels extra difficulty in the night time. These are the few important points we should ask in the history along with the usual and regular clinical evaluation. So here is the example of our low vision clinics sheet, where in this patient with nystagmus and secondary optic atrophy, the distance vision is not improved, but with the near vision correction, the near visual acuity improved from N36 to N12. So we prescribed these near vision devices, low vision devices for him. And in one of the studies conducted by our chief instructor, this is the usual workflow which we follow in our clinic. A patient is first identified in the low vision as low vision, and then he's sent to low vision service chief for ophthalmic workup, and then to optometrist for low vision workup and prescription. And along with that, ophthalmic assistant is also posted for the training purposes. And then patient is followed up every 6 months to see for his routine, how he is improving or how he is adapting with the low vision device. So here we'll take a rest and we'll summarize what the situation is before moving on to our next presentation. That is, what do we have with us? So after assessing, we will have a look at our armamentarium to fight this long battle. So here is the list of all the weaponry we have, which can be classified as optical aids and non-optical aids and non-visual devices. Okay, can have a photograph of this list if you want. The basic principle of LVAs is to magnify, thereby increasing the retinal spread of the images. So these are few types of magnifications, or we use a single type or the combination of these types of magnification in various low vision devices. The object magnification means the simply enlargement of the size of the object. There is no optical system as such, because it makes the object bigger to the visual acuity levels which the patient have. The other one is approach magnification or relative distance magnification. It is achieved by simply moving the object towards a person so that it subtends a larger image on the retina. Few optical systems like hand magnifiers or stand magnifiers use this principle. And angular magnification is the apparent change in the size of the object rather than the actual size of the object. So telescopes usually work on this principle. So there are few limitations with this magnification, because higher magnification leads to smaller field of vision, closer working distance and reduced depth of field. For example, 3x telescope will have 12.5 degree field of vision, and 4x have reduced field of vision to 10 degrees. So the selection of device will thus depend on these factors and not simply on the level of magnification targeted. For distance vision, we have telescopes which can be handheld or spectacle mounted. These have a small but very important role in low vision patients. These are generally used for activities like reading signs or blackboard in school in cases of kids, traffic signals, or even watching TV. So there are two basic designs based on the principle of angular magnification, Galilean and the Keplerian one. Although the Galilean one is smaller, but the Keplerian one provides higher magnification and larger field of view. So the advantage is this is the only optical device which enhances distance vision, and they lead to dramatic visual improvement, but they come with lots of limitations. As I've already mentioned, that they have very limited field of view. Cosmetically, they are not very acceptable because they make the disability more conspicuous when they are using it. And also they are not very cheap as compared to the magnifiers which are used for the near vision. So in this study conducted by our chief instructor is showing the improvement of visual acuity from 162 up to 624. So magnifiers are actually plus lenses that are handheld and used in spectacle plane. They can be used with or without glasses, and they are given for short-term near tasks because they have the problem of increasing fatigue with prolonged usage. Short-term tasks like reading labels, price tags, identifying money, etc., etc., they can be self-illuminated also, which improve contrast. So patients having reduced contrast sensitivity can be given the illuminated ones. Best part of these is low cost and easy availability, and they also work in patients with eccentric vision, where the central scotoma is very big, but they are not hands-free and have limited field of vision as usual, and not for patients with physical disabilities like tremors, arthritis, etc. So to overcome these limitations, we have stent magnifiers, and they are also very important in patients with reduced fields. They can also be self-illuminated types. We also have spectacle magnifiers, also known as high plus reading glasses. They are very useful in patients having binocularity. Base-in prisms are added to compensate for the convergence angle. This we have to think very clearly before prescribing these glasses. And they can be of full frame or the half frame types. And these are cosmetically more acceptable because they make the disability less conspicuous and have the biggest advantage of largest field of view. So this is the same study showing the visual acuity improvement up to N6. And this is an example of an only-eyed patient with advanced glaucoma in the seeing eye benefiting from the high plus reading glasses. And these can be used for monoocular and the binocular purposes. There are few other examples which can be tailored to patients' need, like dome magnifier for those with constricted visual fields, Fresnel lens magnifiers, magnifier ruler or bar. And they have the advantage of offering binocular vision, and they can be used in addition to these spectacles. CCTV is another useful device which uses electronic magnification for the magnification purposes, and it provides magnification up to 40x, which is not possible with any other device. And they also have a very big advantage of reverse polarity. That means the white letters on the black background. So few patients actually benefit from this. But the only problem with this is the high cost and the not so easy availability. And we also have inbuilt tools in Microsoft Office or commercially available softwares like Zoom Text or Fusion for computer users. These enlarges the image also and reads the documents, mails and web pages where patients are severely disabled. And now everyone uses smartphone. So this in itself is a versatile low vision devices because it has many settings like large text, zooming, camera can be used as a magnifier, and it has digital assistant now which eliminates the need of reading and typing. Few cell phone apps, probably if one have attended the previous session, there was mention of these apps like Seeing AI. It offers multiple channels that identifies short text, pupil, products and more. And for low vision users, the short text feature is a dream come true. Just point the phone at text and it instantly starts reading, including handwriting. It identifies handwriting. That is the biggest advantage. And Soundscape is another such app. It can be called as a map with 3D sound. This integrates GPS technology to give visually impaired enhanced information. It's a bit like a strolling with your friend who tells you about the surroundings. Now we have this particular landscape or this landmark. So, and look out, Be My Eyes. There are so many apps coming up now to help such patients. And along with that, we can enlarge the text, and it can be used in many devices like textbooks, phone dials, watch dials, calculators, remotes, which can help such patients. And few other devices which can be used in day-to-day life like Notex, which helps in identifying notes, typoscope, as I've already mentioned, writing and signature guides, talking watches, even needle threader. Another device is sonic canes. Usually we have simple canes which helps in moving them here and there, but sonic canes actually come with a supersonic sensor capable of detecting obstacles in the range of about 25 degrees in the horizontal region and about 50 degrees in the vertical range. And this system causes the cane to vibrate when some obstacles come in their upcoming path. So if we are planning to establish a low vision aid with minimal of resources, we should have these three devices for with us, that is telescope, hand magnifiers, and the half frame prism glasses. If not anything else, you should have these three classes. So I'll take a break here and hand over the presentation to my colleague Dr. Sanjeev Desai.
So friends, we will now talk about prescribing low vision aids, right? So there are 4 very easy steps for prescribing low vision devices in our clinical practice. The first and most important step is to record vision. A lot has been spoken about that by my colleague Vivek. We'll discuss some more later on. The second step is to predict the magnification, decide what magnification a patient requires, and then you select a device for that patient and finally put him on training with that device. So these are the 4 simple steps. Let's discuss each one of them in details. Before I say anything else, let me tell you that this is the testing kit from Keeler which we use in our clinic, and the one on the left is for distance devices, telescopes, and the one on the right is near devices. But this is very expensive. We'd like to keep it simple. So what I'm going to tell you next in later slides will be how you can keep it very simple and do it on your own in your own clinic with the regularly available materials. So the first step, as I told you, was to find out and record the vision of the patient. So if you're using a regular Snell's chart, then for low vision patients, the optotypes have to be really huge like this for him to be able to see. But that is very impractical. So what you can do is actually have special testing charts meant to be used at smaller distances like 3 meters, or you can use a regular Snell's chart that is available in every clinic. Keep the patient, say 3 meters or maybe 2 meters or 5 feet away from the regular Snell's chart and record his vision. And that is a very practical thing to do in our daily clinical work. So we'll talk more about that a little later. But before that, let me tell you that this is the special chart available with the Keeler low vision kit. And this is used at 3 meters distance, and it's got a predictive value. We won't go into all the details. This is the near vision chart, which I have in my Keeler testing kit. This is the Bailey-Lowy chart, which was actually made for low vision testing, and it has metamorphosed into the ETDR's chart later on. And this is again the Logmar chart meant for near vision testing, but we are not going to use it in our clinical practice. So let us stick to the Snellen vision chart, and we record the distance on a regular Snellen chart by keeping the patient at very close distance, say 5 feet or less than 5 feet or even 10 feet away from the Snellen's chart. Once you record that vision, you have to convert it into regular test distance by multiplying the numerator and denominator by a suitable number. So if you see in this example, if you have the vision of 5/200, if you measure it in the American pattern, American system, then you multiply it by 4/4 to get a Snellen equivalent of 20/800 visual acuity. Or if you're using the British nomenclature and you're testing at 3 meter distance, then a vision is 3/24. You convert it and you get 6/48 Snellen acuity. So this is the way how we find out the vision of a low vision patient using this regular Snellen's chart. Then here are the steps to prescribing distant low vision devices. The first and foremost thing is to give a proper spectacle correction, as Vivek has already mentioned, no, Dr. Ali mentioned, that if you give spectacle correction to a patient, then it increases the sharpness of the retinal image and maybe improves his visual acuity by 1 or 2 lines. So that is very important. The second thing to remember is that if the patient has got good vision, like 660 or even 560, and he's able to navigate in the environment, on the streets, in the home milieu, then there is no need for prescribing any distant vision aid. All right? The third thing to remember is that you have to prescribe a low vision device or telescope which is of the lowest useful power. Now there are 2 ways in which you can prescribe low vision telescopes. The first is to use the thumb rule, which is that if the vision is greater than 660, you straight away give a 2.5x magnification telescope, and if the vision is less than 660, you prescribe him 6x or 8x telescope. So this is the easiest thing to do, and as Vivek has already mentioned, a 8x telescope is one of the most useful telescopes, and if you have just one telescope in your clinic, keep an 8x telescope. It is useful for all patients. It will improve their vision and give the wow effect. He'll be able to read down the chart and he'll be very happy. The second way to do it is to first predict what kind of magnification the patient will require and then prescribe a telescope. So here you have to first set a target acuity. You have to ask the patient that what kind of vision do you want? So patient says, oh, I want 6/6 vision, or he says, oh, I'll be happy with 6/18. Or if he doesn't know, if he doesn't have any idea of what kind of improvement he requires, you take a ballpark figure of 6/12 Snellen acuity. And then apply this formula over there that the magnification you require is equal to the desired vision divided by the current visual acuity of the patient. So as you can see in this example, if you want to improve the vision from 660 to 6.6, then the magnification required would be 60 divided by 6, which is 10x. So a 10x telescope is what the patient requires. Now once you find out what kind of magnification is required, you give the telescope to the patient, make him sit in your clinic and give him training, which may be for half an hour, maybe 1 hour. You make him sit in the clinic, put the telescope over his eye, look around, identify objects, look at signs. And then what I usually do is I have my assistant or my ophthalmic assistant or a class 4 staff take the patient out on the streets and make him use the telescope on the streets. And if he is comfortable in both indoor and outdoor use of the telescope, then we finally prescribe the telescope to him. Now the second thing is near low vision devices. How do you predict what kind of magnifier or magnification device a patient requires? And for that, Kestenbaum has given a very simple rule that you take the reciprocal of the distant visual acuity if you want the patient to read newsprint. So if he wants to read Times of India or Indian Express, then if his vision is 6/60, Then you take the reciprocal of that, which is 10, or 10 diopter sphere is what he requires, which is 2.5x if you talk about magnification. Likewise, for N6 vision, you multiply the reciprocal of distant vision by a factor of 1.4, and for N4 vision, multiply it by a factor of 2.8. But remember to deduct the available accommodation as per the line given at the bottom, which is for ages 10, 20, 30, 40, and 50 years. You have to deduct 8, 6, 5, 3, and 1 diopter from the calculated value. But remember, Kestenbaum's rule doesn't apply for all patients. Some patients who've got a central scotoma will require twice the amount of dioptric power that you have calculated by this rule. So this is a rough idea. You have to play with the magnification. Whatever magnification you have predicted, you can go 1 or 2 steps above or even below, depending upon the comfort level and the desire of the patient. So these are the steps when you're prescribing near LVA. First thing is to try a spectacle magnifier. Okay, predict their magnification, give him spectacle magnifier. As Vivek has already told you, it is most unobtrusive. People love them. It doesn't advertise their defect or disability. It can be given binocularly also. The second choice would be a hand magnifier. A stand magnifier is given only in those patients who've got a tremor or arthritis and prolonged near tasks have to be done. Telemicroscopes, which Vivek did not discuss and which are very expensive, normally we don't give it in our practice, are for those patients who require a large working distance for near. Then you shift the patient to reading large print books. When he is not able to read text lower than 18 point, even with high ads, and you prescribe a CCTV when 18 point text is not visible with high ads of plus 32 diopters. And if all this fails, then you ask the patient to shift to reading and writing Braille. So this is something which tells you how much they cost. About spectacle magnifier would cost about 500 rupees, a hand magnifier 250 rupees. Telescopes are very, very expensive, and these are old figures. The last telescope I prescribed was about a year ago, which I had to import from Norway, and at that cost about 16,000 rupees to the patient. So it's the cost has increased and doubled in recent years. So in India, where do you get them from? And these are some of the places where you can buy them from. Baliwala and Homi in Mumbai. And the pictures on the left are from Baliwala testing kit. And this is a very simple kit. One can buy it locally. And then you can get some good low vision devices from Madhu Instruments in Delhi, Acuity Oculoplastics in Hyderabad, and Lensal Optics in Pune. But this is not all about treatment of low vision. You see, if a person has got multiple handicaps or has got profound visual loss, then a lot of other disciplines come into play, and one has to interact with other medical professionals and social workers and special teachers and occupational therapists to treat such patients. And if you're not able to do it, the best thing is to refer to a specialist if you have one in your town. Then environmental adaptation is also very important for low vision patients. As you can see, a tactile floor over there. If you go to foreign countries like Japan, for instance, or in certain European countries, even the pavements or the sidewalks in the streets have got this type of tactile tiles to guide low vision patients. Now on the right hand side, you see the new wing in my hospital being constructed. This was several years ago. And I told the architect to put contrast lines, as you can see over there, the dark brown lines, so that low vision patients can easily follow and go along the corridors wherever they want to go. And it's easy for them to identify and navigate themselves in the hospital building. So this brings us to the end of this session, this section actually. And if you have any questions, we'll take them later after we finish the course. But jot down all your questions and keep them coming after we finish all the sections. So now we'll talk a little bit of light, contrast, and glare, because management of this is very important for low vision patients. Now what happens is, if you see the table down below, this is what the illumination that is required for normal viewing by a normal person. You require about 400 lux of illumination for reading and sewing And for watchmaking, you really require very high illumination, like 2000 lux. So normally it is about 300 to 600 lux. That is the normal illumination you require for normal everyday activities by a normal person. But a low vision person will require very high levels of illumination, which is about 1000 lux, because that helps to increase the contrast to the patient, and it also helps them to break through the mistiness of his vision and see clearly. So how can you get this high level of illumination? Very important and very easy. Make the patient sit in natural light, and if he's sitting near the window, then the patient will receive about 10,000 lux of illumination on a bright day and 2,000 lux on a cloudy day, which is more than sufficient for him to do his reading, writing, and near tasks. The next is to consider how to provide 1000 or more lux with artificial lighting. So the first thing to remember is to use a lamp like that shown in the picture, which is a goose neck lamp, and you can mold it, and you can twist it, and you can turn it so that the light falls exactly where you want it to fall, which is on the object of regard, which may be a book or writing or sewing material. And you can use this formula, very simple formula to remember. Illumination is equal to luminous intensity of source divided by the distance of illuminated area from the light source. So very simple formula to use. And if you're using a 100-watt bulb in the lamp, and you're using it 2 feet away from the book which is being read, then this formula gives you a calculation of 250 lux of illumination. If you want to increase it, you bring the lamp closer to the book, and with the same wattage of bulb, 100 watts at 1 foot, you get 1000 lux of illumination. So when you play with the distance and the wattage of the bulb, you can produce as much as 8000 lux of illumination on the object of regard. So this is how you manage the artificial light sources. Then there are certain important considerations. First is the consistency of the source, which is very important, because if a single tube light, it produces a lot of flickering, because there's a ballast in the tube, and that produces flickering, and especially if the tube light ages. So to counter the flickering, you can have 2 tube lights together, and that one flickering of one tube light will counteract the flickering of the other and cancel it out. So you'll have a consistent light source with 2 tubes or multiple tubes. The second is source deterioration, because with age, the tungsten filament in an incandescent bulb will go down and will require to be changed, because the illumination produced will decrease with time. So you have to keep changing the tubes and the bulbs at regular intervals. Type of source is very important, whether you should use incandescent bulbs or fluorescent bulbs. So this is very important, because for low vision patients, you have to choose an incandescent regular yellow bulb. Why? Because fluorescent sources, whether they are CFLs or regular tube lights, they've got a lot of UV and blue light scattering. And that is very detrimental for low vision patients, because it reduces the contrast. And as you all know, it also impinges upon the functioning of the retina and produces macular degeneration. So a lot of blue light in the surrounds of a low vision patient is very detrimental. Yellow light is very important. It has got virtually no UV and blue, so that is very important for low vision patients. And the fourth thing to remember is that the background illumination must be only 20 to 50% darker, otherwise there will be a lot of accommodative efforts and fatigue to the patient. So now what is the best bulb to use? There you see the emission spectrum of a regular incandescent yellow bulb. So you can see there is very little blue emission, but a lot of red and infrared emission. So this mimics the daylight sunlight pattern too. If you look at CFL lights, you can see the blue peak over there. Very bad for low vision patients. Very bad for us too, also normal people. And here is LED. Everybody is replacing their bulbs with LED lights, and LEDs have got very sharp blue peaks, as you can see in this slide. So CFL and LED bulbs are not recommended for low vision patients. Only a regular incandescent bulb is the best and ideal for low vision clients. So now we have to talk about glare also, because glare is very disabilitating to a low vision patient. For us also it is very disabling, and for them it is more disabling. So glare can be produced either indoors or outdoors. So if there's a lot of glare to the patient outdoors, you can advise him a hat with a brim, or ask him to wear sunglasses or visors. And if glare is very disabling indoors, then the patient should be advised to put blinds and curtains on the windows, or use tinted glass on the windows, or work with back pointing towards the window. Now for outdoor use, there are a lot of absorptive filters that you can use, and these decrease glare and enhance contrast. So they are available in 5 tints. As you can see from top to bottom, they are gray, amber, orange, yellow, and plum. So they are available as standalone glasses or as over prescription eyewear. And the transmission range for different wavelengths is 80% to 2%. So let's discuss them in a little bit more detail. So all these absorptive filters, sunglasses, so the gray ones are basically Polaroids, and the amber, orange, yellow, and plum are made of polycarbonate. All of them block UVA and B 100%. Now, the Polaroids, the gray ones, and the amber ones also decrease the transmission of light equally for all the wavelengths, and therefore they are very good protectors from glare. Best used outdoors. All right? And the orange, yellow, and plum ones, they predominantly cut off the UV and blue light. So they are very important for increasing the contrast for low vision patients. But the only disadvantage of all these colored absorptive filters is that blue color appears black when you wear these glasses, and the color green is not seen. Now let us talk a little bit in the next section about pediatric low vision. So a child who has got low vision has got a lot of problems with motor development, orientation, and it impinges upon his scholastic performance also in school. So it is mandatory that soon as you identify a child with low vision, you treat him as soon as possible. But sometimes when the child is small and pre-verbal, it becomes very difficult to even assess the vision of a child and what potential it holds for him. So for that, it is important to remember the visual developmental milestones, as you can see in this chart over here. That at birth to 4 weeks, a child develops fixation and follows horizontally, objects horizontally. And at 5 months, he develops the blink response, so on and so forth. So if a child does not follow the VDMs, then you must immediately suspect that he has got profound vision loss. So following this or knowing this will immediately make you suspect if a patient or a child has got vision problems or not. So up to the age of 4 months, these are the various ways in which you can also assess vision, like measuring pupillary reaction to bright light, head turn towards light source, or blink response to bright light. In pre-verbal and infants, you can use the Catford drum, VEP, and preferential looking. On the right hand side, on top, you can see the grating acuity LIA paddles. And these are very popular for measuring visual acuity in pre-verbal children by preferential looking. Then for verbal children who are older than 3 years old, you can use tumbling E, HOTV test, Sheridan-Gardner, Cambridge crowding set, but these are very expensive, ranging from 20,000 to 50,000 rupees. And at the bottom, you can see a very popular chart, which is the LIA symbol chart. For those who have got profound visual loss, you have to perform functional vision assessment, and that is the only way in which you can know what the vision is, whether he can perceive light or not, what is using the light for, is vision for, how much vision he has got, and all this. But this is a very specialist thing which normally we don't perform in our clinics. And once the vision loss is identified, or residual vision in the form of perception of light, direction or source of light is identified, you put the child on 3 levels of instruction programs to appreciate light, the direction of the light, where it is coming from, put him on level 2, which is improving his visual efficiency, and then level 3, which is making him learn how to navigate on the streets and in well-defined pathways. So that is how you help a child with profound visual loss to cope up with the vicissitudes of life. And these are few pictures to show you how this is done, how a light is projected and a child taught how to appreciate light and the direction of light and shape of light. And this is a light kit which you can obtain from US, very expensive. I don't have it in my clinic. We don't do it. What we do is the most simple thing. If we have identified a child with profound visual loss, we refer them to specialists. And for me, that is the National Institute of Visually Handicapped in Dehradun or the Blind People's Association in Ahmedabad. Then we consider about what are the new things in low vision. As we are clinicians, we are interested in knowing about new stuff which is coming up. And these are 2x magnifying contact lenses which have been developed by the US military, and this is an experimental military project only at the moment. They are these scleral contact lenses which have these diffraction rings all around them and a central hole. And these have to be used with a polarizing glass, as you can see in the bottom picture. So what happens is that when light goes through the central hole, that's the normal path, and the patient's vision is normal like we see. But once you put the polarizing glass in front of the contact lens, then the pathway of light is changed and it goes through the periphery where it is diffracted internally and gives a magnification of 2.8x. Orcam is a device produced by an Israeli company. It merges artificial intelligence with augmented reality, and it's a very small little device which can be mounted on a spectacle frame, and it reads menus for patients, it reads books for patients, and it identifies faces and tells you who is approaching you. That is Dr. Vivek who's coming to see you now, or that is Dr. Ali. And it's got a very tiny speaker which is quite close to the ear, and it tells you and reads to you things from books, or tells you who's coming to see you when you point that camera or your spectacles or turn your head towards the person who's approaching you. Then this is an implantable miniature telescope. This is about 22 years old, but the only reason why I mention it here is because it is not used very commonly. And it is a very thick device, as you can see, and nowadays more or less it has been abandoned in favor. People are still doing it actually, and it provides 2.2x magnification, but it has been replaced by other devices like this one. This is called the Lipschitz mirror implant, which produces 2.5x magnification, and it uses the principle of the Cassegrain telescope. There's a tiny mirror in the implant, and that mirror magnifies the images. The beauty of this implant is that it is more or less like a regular implant. All right. So in the center, when the rays go through the center hole, that produces the magnification. And the periphery of the lens is used for peripheral viewing, so that the patient can have bilateral implants and he can use his normal vision for navigating in the streets. Whereas wherever he wants to look at a magnified image, he just has to focus through the central hole. And this is an advantage over the previous implantable telescope, because there you have to use only one eye for magnification and the other eye has to be normal for peripheral vision. Okay, we're going to skip this slide, and then this is the new one which has come about 2 or 3 years ago. This is the Shariath Macula lens, and it is a foldable implant in contrast to the other implants which were solid implants. And this is used as a secondary implant to be implanted in the sulcus, and it has got a central optic zone which is of +10 diopters, and it provides magnification for near. The rest of the implant is used for peripheral viewing. So this is a secondary IOL which is new. The other thing which is new, actually 4, 5, 6 years old, is the Bionic Eye, which is produced by Humayun Group in America, and commercially it is known as the Argus 2 epiretinal implant. There's an epiretinal implant, as you can see over there, and it is implanted in the retina, connected to a ring which is actually the receiver, and the transmitter is mounted on a spectacle and transmits the messages wirelessly to the implant. Now, a lot of studies have been done in 2012 and 13 in which people have identified 9mm high letters at 30 centimeters, and some of them could also could read unrehearsed words. So it's pretty successful commercially, and it has been available for the last 7, 8 years. Now they're working on another model for a few years, which is called the Argus 3. And the idea in the Argus 3 implant is to improve the perception or visual perception to recognizing faces. In Argus 2, you can only see a pixelated image, but facial recognition will be possible in the Argus 3. I don't know where it's going to come. They advertised it 2 years ago that is going to come soon, but so far they haven't launched it in the market. Now this group has produced an artificial retina from stem cells, pluripotent stem cells. They've used it from human beings, and they have induced them to transform them into photoreceptors. And they've actually succeeded in producing the whole optic cup with all the 10 layers of the retina with light sensitive photoreceptors. So let us see where it takes us. In the next few years, we'll know if artificial retina will become an actual reality or will remain a myth. Now this is an artificial retina device produced by a Japanese team, which works very differently from the Argus 2 device that we mentioned, because here there is a solid electrolyte medium which is implanted, the blue thing you see, the blue platform you see at the bottom picture. And over it there is an overlay of conductors which are microchannels in which lithium ions move. So when light is presented to this implant, then lithium ions work in these channels in such a way to mimic the neurotransmitters found in the retina, and they send a voltage to the neurons, the ganglion cells, and that produces the image in the eye, as you can see on the right hand side. And this is better image than the Argus 2 implant, they say, because it gives a lot of contrast, which is usually not seen with the Argus 2, which is only basically visualizing of phosphenes. Another new thing is Optogenetics. This is another team which presented its findings in Nature Medicine in July 2021. They've got very limited persons in trial, 3 or 4 persons only, and 1 completed the trial. So it's very early to say it, but it sounds very nice, because what they do is that they have a gene which encodes for rhodopsin, and it is introduced in the retina by a modified avian adenovirus, and it implants into the retinal ganglion cells. So even if the photoreceptors are damaged and are not working, you use the retinal ganglion cells as photoreceptors. And then what it does is that there is a pair of goggles that one wears, which are known as Biomimetic Goggles, because rhodopsin, as you know, is not sensitive to all the colors of light. So they use a very special wavelength. They have not disclosed what wavelength. So the camera picks up the image and converts it into that specific wavelength and beams it on the retina. And the retinal ganglion cells then create an image. They actually create an image. And one person who completed the program in the COVID times was a lady whose vision improved from perception of light to recognizing letters and objects placed on the table, which they concluded was a 57% improvement in vision. So optogenetics holds the key for good vision in the future. And so, ladies and gentlemen, so far as low vision is concerned, we are progressing towards what Mr. Schwarzenegger portrayed in his iconic films, a cyborg. We are not there, but we are going to get there pretty soon. Thank you very much for your attention. And if you have any questions, we can take them now. So are there any questions for Vivek, Dr. Ali, and for me? Or we are done here? No questions? Wonderful. Thank you so much for your attention. Good day to you.